Good evening. Welcome back to my MVF&x and the European Fertility Society. We are back once again to educate you a bit. And of course, we are also here to explain premature ovarian insufficiency, premature ovarian failure. This is our topic today, and we will start with our presentation on this topic. And we have our special guest with us already. You can see Dr. Iván Gimenez Peralta is with us. He's the fertility specialist at 𝐟𝐨𝐫𝐬𝐵 Mediterranean in Almeria, right? We are connected to Almeria this time, so I'm really happy to have you. How are you? Glad to have you here.
Very well, thank you. Thank you, Caroline. Yes, our unit is based in Almeria, that's southeast of Spain. We belong to the UR group, okay, which is an international group. I've started doing infertility in 1999, so it's around 25 years. I did my degree in medicine in Spain, but I did my training in the UK, in the United Kingdom. And I'm working here and been working in Spain all the time, and very happy with my job, my hospital, and my partners.
We are happy to hear that for sure.
I'm very happy to be here today as well.
We are really looking forward to this session. As we already mentioned this before we even started, that this is a specific topic for sure. So remember that if you have any other questions, of course, you can type those in. We are simply here to support you and give you as many answers as possible. As I mentioned, we will start with our presentation on our topic, and afterwards there will be time for your questions. So just put those in the chat, and I'm sure Dr. Peralta will be happy to answer them for you. And remember, it's all anonymous as well, so feel free to ask anything. And it's being recorded, so if you'd like to have a look at this later on, it will be available on our website, myivfandx.com, but also on our YouTube channel. But you can do it afterwards. I already see first question here, but give us some time. Let us start with the presentation, and afterwards, I'm definitely going to publish and show this question to Dr. Peralta, and we will answer them for you. Okay. So thanks a lot, and I think we can go ahead with our presentation. Are you ready as well to start?
Yes.
Brilliant. Thank you so much. Then let's go ahead.
Well, the beginning of the beginning of the presentation was an introduction to myself, but I've already done it. So well, here this is our unit. It's called Unidad de Reproduction Unit, and it is in the Mediterranean. Okay, this is in Almeria, Spain. Right. So the topic I'm going to talk about is the impact of premature ovarian insufficiency or premature ovarian failure on IVF success. So during the talk, I will go through different lines, different issues, such as I will do an introduction. I'll explain a definition of what is POF, which is how I will call premature ovarian failure, just to make it shorter. I will go through some IVF basics, the impact of POF on IVF, options of treatments, in these cases, success rates, emotional issues, and what the future holds for us, and also the conclusions. Well, to begin with, we should know, or probably we know already, that around half the pregnancy, this means around the 20th week in pregnancy, the female embryos, they hold around 7 million eggs. This number of eggs goes down, declines, and by the time of birth, female newborns hold about 2 million eggs. This number keeps going down steadily. By puberty, this number is 200,000 to 300,000 eggs. By the age of 30, the number goes down still further to 120,000, and by the age of 37, the number is 25,000. So in this graphic, you can see how this is 0 would be birth, and here before birth, during pregnancy, it's as I said before, between 5-7 million eggs, and here you can see the slope, how the number of eggs goes down, and here when we can see that we have 0 eggs. This means menopause. Menopause is when a woman runs out of eggs. So the most frequent age for menopause is 50. That's the average age of menopause. But it is considered to be normal between 45 and 55 years old. So some women have menopause at 50, some at 47, 53, but the average is 50. So premature ovarian failure or primary ovarian insufficiency, we call that when the ovaries stop functioning properly. It doesn't mean they stop functioning at all, completely, but properly before the age of 40. So if we go back to what is menopause, when menopause appears, what happens is the ovaries fail to produce normal amounts of hormones, mainly estrogens and progesterone. And also the releasing of eggs may be irregular and non-functioning. So this is why when we have menopause, well, rather than menopause, I would say perimenopause, just previous to menopause, we can find frequently the presence of menstrual irregularities or even the absence of periods, which is called amenorrhea. The fertility is compromised as well during this period. The levels of estrogens are low. The levels of FSH, however, rises, and this is because the brain struggles trying to activate the ovary so that the ovary produces eggs and estrogens and progesterone without success. And this is why, because of this struggle, this is why the FSH level rises. And all this gives place to symptoms which we all know, like hot flushes, insomnia, mood changes, and many changes which we all know that appear during menopause. So all these features are about menopause, but when all these features may appear before the age of 40, and that is when we call primary ovarian failure. In this case, we are relating mainly to infertility. So the features which we should focus on are menstrual irregularities or absence of periods, low estrogen levels, as I said before, altered or elevated FSH, as I said before, but sometimes we can have premature ovarian failure with none of the symptoms at all. So yes, we might find it just because a woman comes to a clinic because of infertility problems and she has no signs of menopause or no signs of mimicking menopause at all. So about the frequency, how this condition happens, we can say that it affects to 1 to 3% of women under the age of 40, and but it's not. It doesn't only happen around the age of 40. Sometimes we can find it in late 20s, early 30s, and so the presence of the prevalence of this condition is relatively low, but it's very significant. So you can see in this graphic how this graphic shows the age of onset of menopause. So you can see all the bulk of menopause is here between 47, 50, 53, but still we can find that by the age of 21 out of 10,000 women can have menopause or premature ovarian failure. At the age of 30, 1 in 1,000, and by the age of 40, 1% can have a menopause or failures of the ovaries. And the etiology or the cause, the origin of this failure of the ovary, it varies a lot. Most of the times, we don't really know what is the origin, what is the cause of this condition, and what is called idiopathic. This means that when the origin is not known, and this accounts for 65 to 80%. 10 to 20% of times, it is due to genetic disorders such as Turner syndrome or women who are carriers of a fragile X premutation. Also, autoimmune disease can also lead to premature ovarian failure. And also because iatrogenic condition, that means secondary to treatments such as mainly ovarian surgery, endometriosis, having had chemotherapy, radiation, and other treatments. So if we find a woman under 40 or 40 who has amenorrhea, that means lack of periods, oligomenorrhea, periods very separated apart, or very short cycles. This means like cycles, for example, of 21, 23, maybe 21, 23 days. We may suspect that there could be it could be a case of a premature ovarian failure. Also, sometimes they can show as well, can present with symptoms of menopause. And as I said before, the FSH level usually are risen, okay? And because the brain is not capable of stimulating the ovary properly, because the ovary doesn't respond, the low estrogen levels, as I said before, like in menopause, may be low, maybe because not always they are low, and the LH is often elevated, but not always it is. So the FSH is more reliable to make a diagnosis. But what happens very often is that none of these appear. Okay, maybe a woman under 40 may not have any of these symptoms, but she may have a premature ovarian failure. And the other thing, the only sign we have is infertility. Maybe it's infertility what triggers the alarm, really. And the other signs, they don't appear. So if we suspect that we could have a case of premature ovarian failure, we should also check for thyroid function, because thyroid alteration, thyroid dysfunction, sometimes may mimic a premature ovarian failure. Also, prolactin should be checked as well. And of course, we should do genetic testing like karyotyping to rule out Turner syndrome, 𝐾𝐨𝐧'𝐭 syndrome as well. And in these women, it is very useful when we suspect that we could be before a case of premature ovarian failure to test for the anti-Mullerian hormone, which is a hormone that shows the ovarian reserve or the amount of eggs remaining in the woman, and also follicle count, which in ultrasound, it shows the number of follicles present in the ovary. These two tests are easy. This is a blood test and an imaging test, and they can give you a good idea about the situation of that woman, fertility-wise. So these women, why? It's not that they don't get pregnant, it's just that they find it harder to get pregnant. Well, to begin with, because there's a depletion of a number of follicles and eggs. So if we have fewer eggs, that means that we have fewer chances of getting pregnant, fewer chances of ovulating. Also, not only we have fewer eggs, but there's a dysfunction of the follicles. That means that it is more likely that we have ovulation dysfunction. We have more likely that we have cycles without ovulation, so it is harder to get pregnant. On top of that, we have problems with fewer eggs and ovulatory cycles, but also the quality of the eggs may be lower. So that means that it is harder to fertilize the eggs. So it's, all these three factors, they contribute to infertility. But on top of that, we have that sometimes because of this cycle and hormonal imbalance, we can have changes in the endometrium, which lead to a lower endometrial quality, or just avoiding or stop or making it difficult for the embryo to implant if there has been the ovulation and fertilization of the egg. But although everything looks like very black, very dark here, in some cases, around 5% of women with premature ovarian failure, they may ovulate spontaneously, and maybe they may conceive naturally. This is unpredictable because we don't know during which cycle they are going to ovulate or not, but that happens. And this irregularity happens. I mean, this possibility of conception happens because the ovarian function goes intermittent, so we can alternate the cycles of ovulation with cycles of anovulation. All this can be a cause of psychological problems on the couple or the woman, causing emotional distress, anxiety, depression, and also mainly because of the infertility, and also because sometimes they may conceive, but the outcome of the pregnancy is very often a miscarriage too. So this is a big issue for women and couples. So, but we have different reproductive options. So we'll go through spontaneous conception, the use of the results of IVF, autologous IVF with the woman's own eggs, and also egg donation. Right, about spontaneous conception, as I said before, about 5% of cases, a woman with a premature ovarian failure can conceive spontaneously. Different treatments have been tried to increase or improve the pregnancy rates, these rates, such as clomiphene, letrozole, aromatase inhibitors, but really the use of gonadotropins as well, but really none of these strategies or methods have proven to be really more efficient than just waiting for spontaneous or natural ovulation. On top of that, we have that there is in these women, we have an increased risk of miscarriage, increased risk of prematurity during pregnancy, and increased risk of stillbirth. But how often this happens depends a lot on the cause of the premature ovarian failure, whether it is genetic. Maybe it's not the same if it is a woman with a Turner syndrome, whether it is a woman with endometriosis, whether it's a woman with POF for another cause. About IVF, which is the next option, here is when we start to do some intervention, really. Well, just to remind you that IVF basically consists of a stimulation of the ovaries to enhance egg production, so that instead of getting just one egg, we get several, so to increase the chances of getting embryos. After egg priming, ovarian stimulation, we do egg collection to collect the eggs. After, once we have the eggs in the laboratory, we fertilize them with sperm, either with a partner sperm or donor sperm. In order to obtain an embryo or several embryos, we culture those embryos in the lab as well, and in the incubator, and then we prepare that embryo for transfer. Okay, but the process is just the same, but the situation is quite different. Why? Because of these women, we usually have a lower response. The stimulation is harder. We have to use usually higher doses because the number of eggs they produce is lower. The quality of the egg is lower, so it affects the fertilization of the egg. Therefore, as a consequence, we get fewer embryos. The embryo quality is lower, and also because the rate of aneuploidy, or the rate of genetic abnormalities of the embryos are higher. And also because of the hormonal dysfunction we were talking about before, sometimes the implantation window, which means the appropriate time to transfer the embryo, may be altered as well. That can affect the implantation of the embryo. So altogether, we have that most of the studies show that a pregnancy rate around 3 to 7%, which is quite low, really considered to the normal IVF figures, which go between 25-30%. So because we get a lower response, as I said before, we have tried several strategies to try to overcome this, like, for example, using higher doses of gonadotropins. And this, using higher doses, sometimes we can achieve a better result, getting more eggs, but at some point, there's one point after which we cannot really increase the dose anymore because the response won't be any better. Also, we have tried to use add-ons, which are some medication, some products which try to enhance the ovarian response, such as androgens, Viagra, aspirin, pentoxifilin, different medication, but none of them has shown really to be more effective than not using them. And as I said before, the quality of the egg is lower. To overcome that, we have tried to do assisted hatching, which is like peeling off the cells around the egg, which is trying to ease or make easier fertilization of the egg. And also there has been a debate about whether it is better to do microinjection, 𝐃𝐨𝐬𝐵, of sperm in the egg when we want to fertilize the egg, or whether it is better to do conventional IVF, which would be to put a concentration, a certain number of sperm around the egg and waiting for the sperm to fertilize the egg. None of these strategies, assisted hatching, IVF, ICSI, has shown to be better than not doing them. So, well, IVF or ICSI, we have to do it, but there's no difference between the two of them, really. So still, we have to keep maintaining a low pregnancy rate. And because sperm is a very important part of IVF, in fact, it is 50%, right? We have tried to use different methods of sperm selection, try to see if we could get the best sperm to fertilize the egg. So we have used microfluidic chips, which is a selection of sperm based on motility, basically mimicking the natural conditions of the female genital tract. It hasn't shown to be any better than not using them. And also we have tried MAX, which is a sperm selection based on the magnetic fields, and they haven't shown to do any better. I have to say that these two techniques, microfluidic chips and MAX, are useful when there's at certain sperm abnormalities, but when the sperm is normal, this doesn't improve the results at all in women with POF. So as we said before, also we have a higher rate of aneuploidy, which means more frequent abnormalities, genetic abnormalities in the embryo. And this is why it is advisable in these women to undergo PGTA, which is genetic testing on the embryos. Basically, to avoid transferring an embryo, which we know that is not going to be viable, it's not going to implant, and in the best of cases, is going to give place to a miscarriage. Because I said that the implantation window may be altered sometimes, we have to pay attention to the luteal phase support, although this is done anyway most of the times in any IVF cycle. Some of the strategies, methods, therapies have been tried to improve the results, and the one that has shown logically has shown to be effective is doing repeated oocyte retrievals. That means that instead of doing one cycle of IVF, just one stimulation, one egg collection, and fertilization of the eggs that we obtain, we do it several times. So at the end of the day, we're getting more eggs. If we get more eggs, we are having. It is more likely that we get a good quality egg, and if we have more quality eggs, it is more likely that we get good embryos altogether. So obviously this is effective because we're just doing, it's like repeating IVF, but instead of doing cycle per cycle, we just collect all the eggs, we fertilize them all together, and then we just manage the embryos we obtained. But there have been some other techniques which have been tried. For example, in vitro activation. That means while we do egg collection, try to aspirate to collect also the immature follicles, immature eggs, and try to mature them in vitro, but it hasn't shown to do any good, really, any better than not doing it. The use of PRP, platelet-rich plasma, is taking injections of PRP, which has growth factors. It consists of injecting it in the ovary, trying to rejuvenate the ovary this way, but it hasn't shown to do any better. We don't really get better pregnancy rates, although the hormone profile sometimes improves, but at the end of the day, we don't get more pregnancies by doing it. And also the stem cell therapy, which is the use of autologous stem cells to rejuvenate the uterus as well, and also it hasn't shown to be any better than not using it. So the best option, really the best results, we get it by egg donation. It consists of eggs coming from a donor, and that's all the secret. It's not that they are superwomen, the donors, just that they are young women with a good hormonal profile, and usually they are up to 32 years of age. They go through a thorough screening of psychological screening, gynecological testing, genetic. They have a family tree study to discover that they are carriers of diseases. The phenotype, the physical features are studied as well, and even we have some software to match donors with receptors, which is called PhenoMatch. So for the donor, it's the same procedure as IVF, ovary stimulation, egg collection, and once we have the eggs, we fertilize them with the sperm to obtain embryos. Then we transfer the embryo to the receptor after having primed the endometrium for such purpose. This strategy, this technique, this treatment gives up to 60 to 7% success rate. So that means 7 times more in the best of cases than autologous IVF. And it is by far the most effective technique. In the future, we have to check for genetic testing for see whether we can detect women who are going into premature ovarian failure, so that we can in time they can just have an ovarian stimulation before they go into POF and then collect their eggs and freeze them for using them in the future. Also, the ovarian rejuvenation techniques, although they are not very effective nowadays, but they may improve in the future. And also, well, we have to wait and see what the future holds for us regarding reproductive biotechnology. So, as a summary, I would say that it's POF is present in 1 to 3% of women under 40. It compromises fertility in an important way, and the autologous IVF is limited because of the quality and number of eggs. The results are not very good, and egg donation is the most effective treatment. So it's important, by family history or clinical signs, try to detect which those women which are at risk of POF, and then so that they can go through egg preservation, as I explained before. And we hope lies in emerging treatments and strategies and ongoing research. Well, thank you very much. I hope you found this talk useful. Thank you for your attention, and I'm open now to any question or comment. I know it's maybe I've been going a bit fast, but it's a long subject, really.
Thank you so much indeed. Happy to have you here for sure. I think it was well explained, and you have shared with us how it works, why it happens sometimes, and of course, you provided some statistics, but also what can be done about it. So thank you so much for sharing that. Now we will go for your questions. As I mentioned, there is a question in the chat already, but of course, I want to encourage anyone. If you have any questions, this is your time, so don't hesitate. You can type the questions in the chat so we can take a look at them and help you out as much as possible. I will go to the question that we've got. It's quite a longer question with some details from Belinda. Let me show you so you have a picture of how it, with all the details. I mean, so I've been doing IVF for 5 years. I'm 45, low ovarian reserve, AMH 2.1 picomole, had 13 egg collections, 10 transfers. You said to use higher dose of stims. I moved clinic to Greece. We now use Mariofert 300 units. And would you suggest trying higher? We are going to try one more time before thinking about egg donation. We only found out in January we have DQ alpha match, so done 2 lit. Treatment just done egg collection and transfer in May. Sadly, negative pregnancy test during the weekend. Anything you can advise here?
Well, to be honest, if you're 45 and your AMH is 2.1, that's a very good figure. Really, I would expect it to be lower. And also, if at the age of 45 you have 13 egg collections, then transfer. Well, to be honest, it depends. I don't think it depends on how many eggs were collected on each ovarian stimulation, but I would say between 40 and 45, unless you can, the unless the response is very, very low. What I would be looking at is really to do for PGTA, because after 40, the most likely cause of IVF failure is that the embryos are low quality or aneuploid embryos. So I don't think in this case it's a problem of low response or low quality, because at the end of the day, she's got 10 transfers. That means that on 10 occasions she's got the chance to transfer an embryo, but we need to know whether those embryos were euploid or not, because that would be, in my opinion, the main reason why she's not getting pregnant.
Okay, you see that there was like an additional information. The 𝐬𝐮𝐬𝐫𝐞 also is very low, right? Only get 2-3 eggs per collection.
Right. 𝐃𝐿 all right. Yeah, but I mean, after 40, that wouldn't be considered a premature ovarian failure.
Yeah. Okay.
Yeah, I don't think above 300 units of FSH, I don't think you're gonna get any better. Sometimes we can try to use long with analogs. Sometimes that can increase the number of eggs that we get. Sometimes using corifoliatropin, but nothing really that with evidence to suggest any changes really.
Definitely, and not an easy answer with the details that you've received as well. So thank you. Excuse me. Thank you so much for your advice here and for your question. And Melinda does say thank you. So thanks a lot for that. And now I will go to the question from Katie. Again, some few details, as you can see. I'm 42. I've been experiencing changes to my menstrual cycle since last November following a fresh embryo transfer with donor eggs using ProStap injection, estrogen and progesterone. Changes including anovulatory cycles, recurring ovarian cysts, changes in periods but still regular. Hormone test done on day 2 of the current cycle show FSH 7.3. LH 14, prolactin 294, testosterone 1.39. Are these results normal? Do they indicate premature ovarian insufficiency or something else? Why did the ovaries not get back to normal functioning after the previous IVF treatment if ProStap was supposed to suppress the ovaries only temporarily? This ovarian disorder did not exist prior to treatment. Anything you can advise here? Again, not an easy question for sure.
Yeah. Well, to begin with, it shouldn't be considered a premature ovarian insufficiency because she's above 40. So, and the definition is below 40. Okay. Sometimes you can get hormonal imbalance. So, what calls my attention is that the LDLH is rather high and compared to FSH. So there's certain hormonal imbalance there, and sometimes this dysfunction of the ovaries can appear. Whether they can appear after an IVF cycle, they can appear spontaneously. It's very likely that it is happening because it had to happen at some point and they have appeared now, but maybe the IVF has been the trigger for that, but I wouldn't say it's a premature ovarian insufficiency. Also, as I said before in the beginning, I would rely rather on AMH and follicle to see whether the ovaries are suitable for IVF, egg collection, ovarian stimulation, rather than rely just on that hormonal profile.
Yeah. Okay. Again, thank you so much. If there's anything else you wish to add and you would like to add any additional questions, you know what to do. Go ahead, type those in. And I will now go to this question. So I have premature ovarian failure during donor cycle, experiencing thin lining too. What's your experience with this, and anything that can be done?
Right. I suppose that you are doing the endometrium. The endometrium is going prepared with estrogens. I assume that, and on top of, and despite that, it's not getting thick enough, or it's getting ready. So to begin with, the first thing I would rule out is a problem with endometrium, such as endometriosis. And for such thing, what I would do is a hysteroscopy to look inside the uterus, see whether there's any condition that cannot be seen on the ultrasound, and sample the endometrium, because sometimes you can get an inflammation of the endometrium, and which doesn't allow the endometrium to grow and develop. And sometimes in those cases, which is very, very frequent, this treatment is as simple as taking an antibiotic, and that's it. Sometimes even everything is normal, the endometrium doesn't grow, and then we can try with different strategies, like using aspirin, increasing the dose of estrogens. There are different treatments for that. Sometimes using whatever we use, it doesn't grow anymore. And sometimes, if you get an endometrium where you have discarded everything and it still doesn't grow, but do the transfer with a thin endometrium, and sometimes you can get pregnancies by doing that. But first, I would study the endometrium. I mean, do hysteroscopy for sure, and endometrium sampling as well.
Okay. Again, thank you so much for yet another advice. I do believe it was helpful for you. You know what to do if there's anything else you wish to add. In the meantime, we did receive one more follow-up from Belinda, from our previous patient who's 45. So you did mention trying analogs and another medicine for my situation, but I didn't catch it. Would you mind sharing some names for me to research? Yeah.
In our unit, sometimes when we don't get the response that we expect, we change to use analogs. Of using analogs of the GnRH, like for example, you have a Synarel, which is a nasal spray. You can have use depends on in the UK. Well, you can use Procrean. It's Triptorelin as well. These are analogs of GnRH, okay? And what we do is that we start with the analogs like 1 week before the period starts. So that takes the ovary to a pseudo menopause before the start of the cycle. In order to, when the cycle starts, then we start the stimulation, but keeping the analogs. So what does is sometimes this boosts the ovary to respond a bit higher. I mean, it's something the results not it's not a miracle, But maybe if you are due to get to obtain 2 or 3 eggs, sometimes you can go up to 4 or 5. Sometimes you just get the same. But but usually we use antagonists like ganirelix. But as I said, when it doesn't, we don't get the number of eggs that we expect. We use the analogs, and that is starting with the analog 1 week before the period starts, and then with the period you start the stimulation. This is the way that IVF used to be done maybe 15, 20 years ago, before the antagonists appeared. It's a classical way of doing IVF, and it was abandoned. Well, not abandoned, but it was left apart because the risk of hyperstimulation was higher by doing this treatment. But in women whose response is going to be low, you want hyperstimulation. That would be a blessing, really.
Yeah. It's true. For this one, yeah. Thank you so much indeed for yet another answer. I do hope it was helpful, Belinda. Anything else? Yeah, amazing. Thank you. This is the comment from Belinda. Thank you so much indeed. I do not see more questions, but of course, I want to make sure that we've answered all of your questions. So if you have more, go ahead, type those in. If not, we will be finishing for today. But as always, I want to remind everyone that if you wish to ask anything, I'm sure that the Dr. Peralta and the team will be happy to take any of your questions. So you can get in touch with them directly, or you can simply forward any questions to me, and I'll be happy to forward them as well, as you know, so don't hesitate. Someone is typing, so let's give it a minute. Let's see if we have more questions. If not, we will be finishing, but thank you already everyone for joining. Thank you for your questions and for your time, because thank you so much for spending this evening, this 1 hour with us, and on this not easy topic, for sure not an easy topic. So thanks a lot for that. And Dr. Peralta, I think that we will be finishing. Any final words, anything you can add before we finish?
No, I said that when it is frustrating, and because sometimes you expect a result that you don't get, and I think the key thing, I mean, two things. Is one according to and to one's beliefs and one's thoughts, you have to considering egg donation. I know it's something very personal, but it is something that it is always there. And the other thing is that we have to make to have very clear who should keep trying with her own eggs, because sometimes the problems we have in the units that some women on some women who have this problem, we encourage them to keep trying, because we see that that the success may be around the corner. But there's some other women who want to keep trying, and sometimes we discourage them from keeping going, and they don't want to stop. And sometimes I think it is very important, because also psychologically and for everything, it's important to know when to stop, when you know it is not working.
Sure. Thank you so much. I think it's very important to keep that in mind. It's never an easy. We've done plenty of events on when to stop trying with own eggs and move on to a donor eggs. We've done it many times because we know it's not like only. I think it's more psychologically at some point, right? So that you need to actually make that decision, and definitely not an easy one. So thank you for pointing that out. One more question, short one before we finish. Could you please tell me what LH levels are considered normal on day 2 on the cycle?
Well, it varies a lot, but I would say from 1 to 5 or so, but it's very variable.
Yeah, individual, right? So
it also it really varies even more than FSH, because even in women who have polycystic ovaries can have a very high levels of LH. Depends on the age as well, because the younger usually the higher the LH will be, but it varies a lot really.
Fine. So you need to look for like your specific kind of situation, I guess, right? Okay, that makes sense. Again, thank you so much. Hope that helped. I'm seeing that someone is typing, so again, I want to make sure that we've answered all of your questions. But again, as always, if you have anything else and we will not have time, or we cannot answer this right now, we will definitely be happy to receive your questions. And there's a thank you again for this session. And I couldn't agree more. Thank you so much. I think it was very informative and very useful. So thanks a lot. Again, not an easy topic, not the, let's say, most popular topic, of course, but we are happy to discuss any topic that can help you out. And I think it was really useful. Dr. Peralta, thank you so much for joining us today, for your time. I know it's been a busy day, and I'm sure you are ready to go home as well after a long day, huh?
No, thank you. Thank you very much. Indeed.
Thank you so much. Thank you so much indeed. As I mentioned, please remember that we will be back, of course, with some more events. And we are actually live tomorrow, but we will talk about pre-IVF testing. So if this is something you are also, if you're here and are also wondering how it works, I can only encourage you to join us tomorrow at 7 p.m. London time. There will be 2 fertility specialists who will discuss pre-IVF testing, scans, diagnosis, etc. So you will have again a chance to ask your questions. Thank you for today, everyone, for joining. And Dr. Peralta, thank you so much for your time as always. And I'm really happy to have you here. Take care and have a lovely evening, everyone.
Thank you, Caroline, and thank you to the assistants as well. Thank you very much.
Thank you so much. Take care. Bye.
Bye.